All of us, and this is published in December 2021 in Fertility Sterility. It talks about toward more accurate prediction of future pregnancy outcomes in couples who are suffering from unexplained repeated pregnancy losses. And don't you think this is such an important thing? Because after having two or three or more losses, the only thing couples keeps on asking us, "Ki, what is the chance of having a live birth?" So we need a model, a prediction model to have this. And what should be the quality of a prediction model? Firstly, the prediction model should have a good discrimination capacities and an area under curve of zero point 0.7 and more. Ideal is 1, but area under curve beyond 0.7 could be having a good discriminatory power where this predictor factor can discriminate of a good success of pregnancy, a live birth or no. Secondly, there should be a good calibration. What I mean by calibration is there should be a consistently good agreement between a predicted factor and an observed factor following that. So your prediction model should be calibrated against the observations what you observe in a very good consistency. And thirdly, it should be very easily clinically applicable, and that's when we can use it up and our patients will be at much more at peace, and that will give us quite a liberty to counsel. That will be one good counseling tool available to us. So what is the chance of having live birth is the commonest question, as I already told you, is asked to all of us. And the candidate predictors which this model has looked into is the age, and they looked into the model, the predictor factors of the couple. It's not just one person, not the women factor, it's the couple which has been looked at. So they looked at the maternal and paternal age both. They looked at the number of losses suffered, looked at the body mass index of the couple, again not just the maternal body mass index, and the smoking habits of the lady and the husband. But they have missed on the data of the Apla syndrome, thrombophilia. They are not reported data on sperm DNA fragmentation, and whether any intervention was done like heparin, aspirin, steroids were used, that has not been mentioned. And the couples were followed for 1 year after 2 or 3 miscarriages, and 66% of 526 couples followed, and they had at the end of next 1 year they had about one ongoing pregnancy. That itself says that the success is pretty good. And in 34% patient without an ongoing pregnancy, they did report an abortion or an ectopic pregnancy or an MTP for a fetal anomaly. So a large chunk of them achieved a pregnancy, and 66% were having a good ongoing pregnancy. Maternal paternal age and the body mass index has a relatively linear relationship with the live birth rate. As the age advances or the BMI advances in the maternal and paternal factor, the chance of pregnancy does go down. But it has not been statistically significant that has been observed in this particular study. I would like to say the maternal BMI and the risk of miscarriage, a typical U-shaped relationship. So if you plot body mass index on the x-axis and the maternal age, miscarriage risk on the y-axis, at a very low body mass index, you always have a very high miscarriage risk of, let's say, BMI less than 18, and one with BMI beyond 35, again, the chance of miscarriage does increase. So that's a U-shaped relationship. I think having such kind of model to predict who is a high risk person and low risk person in women or the couples who are suffering from unexplained infertility is very much desired. So that will give us some evidence to hold on to counsel our patient. But obviously, long prospective studies are needed, noting on all the predictive factors and seeing actually what happens to those couples as they go ahead in life, and how many of them achieve a positive ongoing pregnancy and how many suffer from a repeat abortion. So long-term prospective studies are needed.